I got smiley faces on today because it's on my last lecture. Without further ado, let's get started on Module 12, number 3, objective. I hope you're as excited as I am. All righty. Module 3, Module 12, Objective 3, is to discuss the ideal relationship between theory, evidence, and practice, and then the barriers to implementing this relationship in addiction work. So, ideally, what do we want, and what do we got in addiction? Okay. So the relationship that we want between theory, evidence, and practice is this. So we have a theory. For example, let's say social learning theory, right? And then there's evidence that can lead to collecting empirical evidence, right? So we would get some data collection to test that theory. Now, at the level of basic evidence like that, a lot of times it's done in research labs. Okay, so that evidence portion a lot of times is not done in practice settings. So at any rate, it goes back and forth because let's say the evidence doesn't support this theory, then you got to go back and tweak the theory. So we got the double arrows there. Okay, but once we start to see that the evidence is really there for a particular theoretical orientation, right? Then we want to transfer it to practice. Now, the practice part is really, really important. Here's why. Because sometimes things can work in a laboratory setting, but not actually work in a real life setting. So we have to make sure it works in a real life setting. So when I say adoption and implementation of new practices based on the evidence, this is when we adopt a new kind of technology, a new thing that we've seen in the evidence works, we've seen in the scientific studies works, and now we're going to evaluate the outcome in the practice setting. Now, that will inform the theory as well. And sometimes if we find it doesn't work in the practice setting, then we got to go back to the theory and say, well, you know, the theory needs to be tweaked a little bit because it works in this setting, but it doesn't work in that setting. So, ideally, all of these kind of work together. But in the case of addictions, a lot of times it doesn't work. Okay, so there are different kinds of research, and a lot of times those are sort of seen as dissimilar to one another, and they are dissimilar in some ways, but a lot of times they're seen as opposing, and they're really not. We really need both of them. So we've got what we call efficacy research, and efficacy research is like the randomized control trials. A lot of times these are done in laboratories or in other settings rather than treatment settings. I want to say, I don't want you to think it's like a lab with test tubes and stuff like that. They're strictly controlled. People are randomized and their conditions are completely controlled to make sure that those two groups are exactly the same except for that treatment. So everything's really well monitored because we want to make sure that the treatment is the only difference between groups. So here's where we see those randomized control trials in efficacy research. But then there's also what we call effectiveness research. And effectiveness research are those program evaluations I described last time in the treatment setting. So typically a program evaluation is going to be a pre-post study or before and after study where you look at how your clients are doing prior to the program being there, and then you look again after the program is there. And if they improve after the program, then we're going to talk about that as an effective program. Now, it's not a randomized control trial. It's really not that great as an experimental study, right? But nonetheless, we're trying to demonstrate that that this treatment works in a real life setting. Okay. So I want you to think about these two terms: practice-based evidence and evidence-based practice. Those are two different things. I've been talking when we talk about effectiveness research, we're talking about practice-based evidence. That's where that evidence is coming from. It's evidence that, remember in the last slide, may affect the theory here and importantly contributes to the theory, okay? But we talked last time in objectives 1 and 2 about evidence-based practice, and that's where practices are implementing evidence that has been shown in laboratory studies. So they're just using it. They're not necessarily producing evidence of their own. Okay, so the emergence of evidence-based practice. What's happened is remember I was saying evidence-based practice only really originated like in the 1990s, where that became sort of a standard for people. And so it's pretty new actually, evidence-based practice, and that being a standard in mental health and medicine, but even more so for addiction treatment. And there's reasons behind that. There's a lot of strange things about addiction treatment. So a lot of people, a lot of even mental health providers don't provide addiction treatment. And part of that is that addiction is stigmatized, that it is seen as sort of different from other areas of mental health. It's also been separated from physical health as well. And so a lot of medical providers are not doing the same kind of, are not doing addiction treatment either, right? So they're referring it out. And under the law, there's still a separation between addiction treatment and other kinds of mental health treatments in some settings, or medical treatments. Like, for example, methadone treatment has to take place in a certain kind of clinic, right? You have to access it in a particular type of clinic, methadone. It can't be used with other, you can't just get it from your doctor, right? Okay, so that's part of the things. There's been a lot of separation between addiction treatment and other treatments. Okay, so how did evidence-based practice actually emerge? It has to do a lot with federal legislation that basically said, even though we've known forever and people have treated addiction as a disease forever, still it was so separated out from the medical field, and the addiction providers were actually, many of them were not even educated in a typical, sort of psychological mental health fashion, much less a medical fashion. And so anyway, a couple of different pieces of legislation came down the line, and you may or may not remember this or be old enough to remember when the Obamacare, or the Affordable Care Act, and Mental Health Parity and Addiction Equity Act. Well, what parity means is that we're going to treat something the same, right? And so in 2008, an act was passed called the Mental Health Parity and Addiction Equity Act. And what that did is it required health insurance companies to cover mental health and addiction treatment in the same way that they would cover medical conditions. Because what was happening is that insurance companies were just saying, oh, well, we're not covering that. Oh, we'll cover treatment for a depression, but we're not going to reimburse for treatment for addiction. They had choices, the insurance companies, and many of them were not basically paying for this stuff. So people weren't able to access it. Okay, now the Affordable Care Act extended those requirements to Medicaid. So what is Medicaid? Medicaid is health insurance, government provided health insurance for people who make under a certain amount of income. So we're talking low income people. Medicaid plans also were not covering reliably addiction treatment, depending upon the state. And so under the 2010 Affordable Care Act, that forced them to cover addiction treatment. It forced them to cover smoking cessation programs and things like that. And the overall goals of these is that we would get some integrated care, that we wouldn't have addiction care being over here and physical health care being over here, and mental health care being over here, that we would be able to integrate some of this stuff, okay, and pay for it in similarly. Okay, well, it turns out that, and like I said, we talk about, evidence-based practice, but you can't really trust that because it means different things in different places. Number one, we talked about last time, the evidence part of it can mean good evidence, or it can mean crappy evidence, or it can mean, empirical evidence, or it can mean, other kinds of evidence, so testimonials and stuff like that. So we got to be careful. But another thing about EBP is that it varies a lot by context and profession. So we have evidence-based practice, what we call evidence-based practice, and then we have empirically supported treatments. So treatments that work are not necessarily included in evidence-based practice, and here's why. In psychology, what we see is an intersection of three things we define as evidence-based practice. It's research, and by that I mean the randomized control trials, and we do use those, and they're important. But we also use clinical expertise, because clinicians know what is working out there with their clients and what things they would be able to implement, maybe because of cost considerations as well with their clients. And then finally, we use the client factors, because a randomized control trial that has been done on one group of people may not work in people with a different culture or with different preferences and things like that. So that is an issue of what we call, if you took research methods, external validity. If it works in one place, will it work in another place? And so in the APA, or American Psychological Association, basically said, we're going to use all three of these, and this is what we're going to call evidence-based practice. But remember, empirically supported research is only one part of that. In public health, they want to do, the research, the science-based interventions, in addition to looking at community preferences. So in different fields, it varies quite a bit, because it's like the idea is, what are we going to call evidence-based practice? But that's another reason for you to sort of mistrust that word evidence-based practice when you see it. You really have to find out, okay, what field is this in? What is the standard of the evidence, and things like that. Okay. Criticisms of evidence-based practice across different fields is that there's too much emphasis on the science, on the randomized control trials, and not enough emphasis on the context that it takes place, the culture of the clients, the resources that are available in the community. So we have this sort of high internal validity. And again, if you've taken research methods, you'll understand these terms, which we know that this stuff works. That's internal validity. But we only know it works in this population that the study was done on. We don't know if it's going to work over there. That's external validity. So the research emphasis is on internal validity. We want to know that it works, not on external validity. So there's a lack of clarity of the evidence, and we talk about that. What is good evidence? So there's a lack of clarity there. Sometimes this stuff is just really expensive, and though it might work, it's not going to work in a treatment facility because it's too expensive. They can't do it. And then the idea that funding comes from policymakers, who are a lot of times government officials. And it takes kind of a top-down process where they say, you're going to use this stuff that works. We know in the literature that this works, so you're going to use this, and we're only going to give you money if you use this. Part of the problem with that is that the practitioners, the people who are actually out there, and the clients, they don't get to be heard in this process. So there are problems in general with this standard of evidence-based practice. Okay, one of the ways in which policy makers have enforced evidence-based practice is called performance-based contracting. And this is the idea that a funding source, like, for example, Medicaid, right, which you remember is government-sponsored health insurance for the poor, will say, well, we're only going to reimburse for Medicaid in your clinic if certain performance standards are met. For example, your treatment program must show at least a 15% abstinence or reduction in 6 months after treatment completion, or something like that. They make some kind of standard, and they say, we are only going to pay for Medicaid patients to come to your clinic if your clinic is meeting that standard. So it's performance-based. The problem with that is that the evidence-based practices that they want people to use, which are those supported by science, are not always synonymous with cutting costs or cutting time, and so a lot of times it'll be really expensive. And, the main goal at the level of the treatment center is to improve client outcomes. In the long run, if they can make it cost effective, that's even better. But to implement a very costly thing when they're counting on reimbursements, Medicaid reimbursements, which are not very high, that becomes sort of a problem. Okay, so the technology transfer is basically when you take an evidence-based treatment and it's been supported by the randomized control trials, and now you're going to try to put it into practice. Okay, so it's a transfer of new technologies, and I know we don't think of these as technologies, a lot of times a new treatment, but for the purposes of this, think of it as technology because this is a general term. It is basically taking an empirically supported treatment and getting it to the treatment center. So how do we do this? How do we get this stuff in there? So getting it in there is called technology transfer. So we're connecting the providers to the evidence-based practices, right? And it requires an adoption of innovation. These providers have to say, well, okay, we're going to adopt this new practice. We're going to adopt this new treatment, right? And that is really, really hard to do because there are a lot of barriers to implementation. Now, you've known this probably from any institution you've ever been in, right? Including this educational institution, including every place where you've ever worked. There's a resistance to change. People do not want to change what they're doing. You know what I mean? And part of the problem with changing what people are doing is that you also have to train them to do something else. So if you're going to adopt a new treatment that's been shown to be effective in the literature, now you got to train all these people on that treatment. That's got a cost behind it. And then you got to make sure that they're doing it right. That's what we call fidelity of practice. On top of that, you have to have a decently structured organization. It cannot be dysfunctional, because if it's dysfunctional, the organization, then you're going to have all kinds of financial problems. You're going to have staff turnover. It's just going to make it impossible to adopt a new type of therapy, a new type of treatment, and actually do it right. And so when these barriers are low, implementation is more likely to occur. But when we're talking about treatment, when we're talking about people with substance use disorder, they a lot of times do not have a lot of resources. And so you have a problem, with basically, low income treatment centers with low funding, right? And a lot of times it can be pretty chaotic out there. You'll see if you ever work in a situation like that. Another thing is sustainability, because assuming you can get everybody trained and on board and doing it right, can you sustain that through other changes in the organization or through staff turnover, whatever? That's an issue. Okay, there's not enough focus on implementation of the EBPs for addiction. You just don't have enough. If you look at it in addiction, what you see is we get this development. I'm trying to use my cursor here, but I'm not finding it. The development of a new treatment, right? Which is the theoretical development, the empirically supported randomized control trials, all gets done, and that's great. And then we want dissemination, which is usually publishing in scientific journals and getting it out there for people to see. And then once we get implementation, that is when it goes to the treatment centers, right? What our problem is that we focus a lot on the RCTs. We focus a lot on dissemination, right? Which is getting all this information out here. Here's these effective treatments. Here's these effective treatments. And that's what I've been doing on this whole class, haven't I? I'm focusing on that. But what about getting those treatments into the actual treatment centers? And we've got this huge problem with implementation. We're not getting it there. And without that implementation, we've got basically a glitch in the technology transfer program. Okay, I want to get now to the final take-home points of Module 12. How we define evidence varies quite a bit, right? And so what we say is evidence can be low quality evidence. It can be very high quality evidence. Low quality in the form of expert opinions or personal testimonials of patients and things like that. to high quality evidence, which is those randomized control trials and systematic reviews of randomized control trials. We've got to review the type and quality of the evidence, because the term evidence-based practice is basically pretty meaningless, because it could be good evidence, could be bad evidence. There's a difference between evidence-based practice, which is treatment centers that are using the evidence, and practice-based evidence, which is looking at for evidence of the effective use in a treatment center. So that would be like the before and after study that takes place in the treatment center. We call that program evaluation. Efficacy and effectiveness trials are both important. One having to do with the laboratory studies and the effect and the efficacy, and then the effectiveness being practice-based research. Finally, implementation of evidence-based practices is crucial for addiction treatment. If we want to be able to meet consumer demand for addiction treatment and do better at it in the community, we got to be using stuff that works out there, and we need to remove those barriers. So all of those are policy issues. Bye. Have a great